Hi, I'm Bruce Neal from the George Institute for Global Health at the University of New South Wales in Australia. And I'm joined here today by Michel Bernier from the University of Lausanne in Switzerland. We're going to talk through some current controversies around the issue of salt and cardiovascular health. I'm going to turn over, first of all, to Michel and ask him to summarise some recent research that's been presented here at the ESC. Michel.
Yeah, hello, Bruce. I would like to summarize a very interesting Peruvian study, which has been done in several villages. Actually, it was 6 villages from the Peruvian country, where the investigator actually went into the homes, took out the salt, the regular sodium chloride, and replaced it by sodium, a different sodium chloride enriched with potassium. And the goal was, of course, to reduce the salt intake, maybe also to increase a little bit of potassium intake. And they not only followed blood pressure, which has been done previously with a similar design, but they also looked at the incidence of new cases of hypertension in these populations where most people were not hypertensive. Some of them were. And of course, as expected, I would say, they found during the period of observation significant decrease in blood pressure, both in normotensive and in hypertensive. And as expected, the decrease was greater in hypertensive than in normotensive. But I think for me what was the most important thing is that, because that would have been expected, a similar study was done in Portugal some 10, 15 years ago. But when they looked at the incidence of new case of hypertension, they really demonstrated a 50% reduction in the incidence of new hypertension in this population. Yeah. And let's say, to me, this is a good indication that at the population levels, if one really changed a little bit and reduce the salt intake, and of course also increase the potassium intake, which is probably an important issue in this paper, we can actually prevent the development of hypertension. Maybe we don't know how much we retard. We don't know if it's only a couple of years or more, but it has already at the population level a significant effect.
Michel, let me ask you a couple of questions about that, because one of the things that struck me was that the reduction in systolic blood pressure was pretty small, about 1 to 2 millimeters of mercury, but the reduction in incident hypertension was a 50% reduction.
Absolutely.
The two of those sort of seem incongruous to me.
Well, you're right. Well, at the general population level, it was about 2. In the hypertensive, it was a little. Well, it was more closer to 1.2 in the normotensive, and around 2. But if you look at the epidemiological studies, 2 millimeters of mercury corresponds.
Oh, don't get me wrong. I mean, 2 millimeters
is already important in the population level. So that means also that probably a lot of these patients, or let's say not patients but subjects, I would say, were at the margin probably of hypertension.
Right.
They were not really low, because that in the normotensive it should not do. But they're probably an intermediate portion of the population which is just around the 140 over 90. Yeah. And yes, you're right. It may be the discrepancy between the small amount and the huge amount of, let's say, the 50% decrease in the risk is important. But it confirms what we used to say, that every millimeter counts in terms of blood pressure.
One of the other things we have to consider with this trial is that it was a substantive project done over a reasonable time frame, but it had only a limited number of clusters. There were a limited number of people. Yeah. There's probably a degree of imprecision in some of the estimates as well. So they might have underestimated the blood pressure a bit. They might have overestimated the effect on hypertension a bit as well.
Yes, that's true, and we cannot exclude also some contamination of salts that they may still have used.
So that's another interesting point, isn't it? Because they got an increase in potassium, but they didn't see a fall in sodium.
No, this is actually quite surprising. Yeah, that the amount. So it's. These are signs that we have seen in other studies, is that as soon as you reduce the salt and replace by the potassium, people tend to perhaps use more. Yeah. So really this study points out, is it really the sodium decrease? Because overall on 24 hours they don't see any sodium, or is it the potassium increase? studies. Yeah. And there are lots of studies, showing that potassium has a very beneficial effect, and not only in terms of blood pressure reduction, because if you increase sodium intakes, you also promote sodium excretion. Yeah. So you eliminate a little bit more of sodium, and this has been shown to be lower, and also to lower the risk of stroke in many patients.
I'd like to get your thoughts on a recent piece of research around this issue of lowering sodium and whether it's good or bad for you. Mm-hmm. We've obviously, had much or heard much about the PURE study and this apparent, U-shaped association where people with high sodium, high risk, but also people with low sodium at high risk of cardiovascular disease. Now, there was a recent reanalysis of the Trials of Hypertension project where they tried to understand a bit more about why this might be happening. And the key issue that's been raised with the PURE study is that it doesn't use measured 24-hour sodium excretion. It uses an estimate based upon a spot urine, where you basically take an equation that includes height, weight, age, and a number of other things, and you estimate the 24-hour, and then you associate that with risk. Now, myself and others have been a bit critical about that, because effectively what you're doing is sort of creating a risk score of which sodium's a little bit, and then saying that it's the sodium that's driving that association. So in this new analysis of the Trials of Hypertension project, they estimated the association with the measured 24-hour, and they saw a linear association, so no J-shape. Then what they did was they estimated just using the spot and the equations, and they showed that you got this J-shaped association. So do you think that clears up the question about the PURE study?
I don't know if it clears up the controversy, but at least I think it's a very good point. Because when they use the concentration, they use a ratio of sodium over creatinine. Yeah. And of course, the major issue for those with a high mortality and the low sodium concentration, I must say, more than low sodium intake, is this low sodium concentration really reflecting, the sodium intake, or they have other factors. And of course, if you introduce the creatinine, so the creatinine is an indicator of muscle mass and also of your health in a way, because if you are malnourished, you have a low creatinine, you have a low, and this may actually contribute to the mortality rate, which has nothing to do with the salt. The salt is just an indirect measurement of that people are not in a very good shape, and I think this is a very important. And the fact that you can actually, I love this analysis, because they look the top trials. They take this data and they actually can change the form of the relationship into what people usually get with the sodium concentration. And those who really have used, like in the trial of hypertension, they have several measurements of 24-hour urine, which is also another aspect which is very important, because, basing everything you will have in the future on one measurement, which was not really very standardized also in the PURE. And in my present,
let me interest you. So one other question I just want to ask about that potassium is: there's been a lot of concern about potentially increasing the risk of hyperkalemia in patients. Do you think that's a real issue or not?
This is a real issue in patients with CKD.
But with severe CKD or patients with mild CKD
we say usually probably people below 30 millimeters.
Right, so sort of getting sort of down to stage 4
it's really 3B and 4 and 5. Yeah. But before, I think there are absolutely no risk of hyperkalemia. If you eat more bananas one day, so you also have more potassium intake. A lot of the potassium we eat goes away anyway in the stool. So it's but I don't think the risk of hyperkalemia in the general population is really.
What do you think this Peruvian trial is going to mean for the use of salt substitute? Do you think we're going to see it taken up a whole bunch more, or do you think we still need more research in this space?
No, I think we still need more, but there are, as they say also in this Peruvian study, is that there are a lot of studies that have been done in China. Yeah. In China, in the elderly homes, and where they changed, where some studies were very positive. Yeah. They actually showed a benefit. Some studies were negative, and there is still controversial. Yeah. And I think it's good that some studies are done outside China, which should be done perhaps in Australia or in Europe. But I think it's difficult. For example, I tried to do something, for example, in Switzerland, to put more potassium to replace the sodium. But the authorities actually don't want that, not only because they are afraid of potassium to a certain level, but they would like to decrease the salt appetite of people, which is a very, very difficult thing to do. You know, it's probably very inside the populations, and I'm not sure we can get that one day.
So we're getting to the end now. Just wanted to finish by talking briefly about that new research. And I'm not sure if you're aware, we've got a big project going on in China again, I'm afraid. But 21,000 people randomized to salt substitute or usual salt. We're just starting the final follow-up after 5 years intervention. And we hope in about 12 months' time to be able to come and talk about the effects of salt substitute on stroke and mortality.
Yeah, that's great.
So I think we'll leave it there. Thanks very much for listening. And Michelle, thanks very much for chatting.
Thank you.